Welcome to this in-service on glycemic control in cardiac surgery patients. My name is Peter. I'm one of the clinical pharmacist specialists here at St. Francis Medical Center. And in particular, we'll be talking about the introduction of St. Francis Medical Center's new modified Portland protocol. Now first we'll go into background. So what is the point of this in-service? Hyperglycemia in critically ill patients has been associated with increased mortality and infections. A recent guideline from 2012 with the Society of Critical Care Medicine actually recommends a blood glucose target range of 100 to 150 with an absolute maximum of 180. So most of the time our patients, especially our cardiac patients, should be within 100 to 150. And while the patient may trend out of range on occasion, definitely greater than 180 has been associated with significantly increased infection and mortality. Also of great significance is the new introduction of CMS 2014 SCIP core measure requirements, which, as you see, cardiac surgery patients must have controlled postoperative blood glucose levels less than or equal to 180 in the time frame of 18 to 24 hours after anesthesia end time. In summary, every blood glucose level that is taken from the patient from 18 hours through 24 hours after anesthesia end time, which is a total of 6 hours, must be less than or equal to 180. Now, this is a big change from prior to 2014 where we only looked at one single blood glucose level at 6 a.m. So this is looking at a bigger 6-hour window where we have to be compliant. So the point is we have to achieve now sustained glycemic control. After a root cause analysis of why we've had fallout in the past 4 months, we saw that there are three main culprits of this. One, current insulin fusion target blood sugar range is way too liberal, 140 to 180. Also, we have underutilization and premature discontinuation of insulin infusions. And also, we didn't take into account what happened when the patient eat. So post-meal hyperglycemia is also a big cause of fallouts. Solutions for improved compliance, as you can see, are in direct relations to the prior three issues. With the introduction of the Portland Protocol, we will have a more aggressive goal of 100 to 150. It'll be ordered for greater than 24 hours, or at least 24 hours. And there will be guidance on post-meal subcutaneous humalog dosing in addition to the insulin infusion. So a little bit about the Portland Protocol. The Portland Diabetes Project was started in 1987, and multiple studies have showed that reduced mortality and infection rates with adequate glycemic control in cardiac patients have been significant. The actual Portland Protocol was copyrighted and published in 1992 with ongoing revisions and improvements throughout the last couple decades, and it's the most well-evidenced protocol that addresses all of our current compliance issues. And of note, this is a protocol that is used at hundreds of hospitals throughout the world, and including community hospitals like St. Francis. Now, in outline of the Portland Protocol, we'll briefly go over blood glucose monitoring guidelines, how to initiate the insulin infusion, how to titrate the insulin infusion, the significance of postprandial subcutaneous insulin, and also how long we should keep the insulin infusion on. While we look at the Portland Protocol, it may look intimidating and lengthy at first, as it is, admittedly 5 pages versus our 1-page prior ICU intensive medicine protocol. The intent is that after this in-service, we'll see that the vast majority of the time spent with this protocol will be spent on actually titrating the insulin drip, mostly on page 2 to 3. But real briefly, if you can look on the protocol provided in front of you, we can see that through the 5 pages, page 1 is actually dedicated to starting the infusion. Basic documentation of how frequent we want to monitor the blood glucose. But really, you no longer need to refer back to this page unless the infusion is held or stopped for some reason or needs to be restarted. Page 2 to 3, this is where 90% of your time will be spent. While it may look wordy, we can find that it's very detailed and clear as to what action is to be taken for every possible situation. And it's the same as any other insulin protocol in that each AccuCheck will require you to take some sort of action. There are no complicated mathematics or multipliers involved in this protocol. And page 4 to 5 will only be used when the patient has a meal. Otherwise, you'll spend most of your time, again, on page 2 to 3. Now we'll go through an overview of the Portland Protocol, starting with blood glucose monitoring guidelines. So again, your target glucose in the Portland Protocol is 100 to 150, which is much more aggressive than our current general ICU intensive insulin protocol. Blood glucose monitoring guidelines will be Q1 hour AccuChecks as before until at least 24 hours post-op. Again, we want to keep this insulin drip on for at least 24 hours. Now, in some instances, the frequency may increase to Q30 minutes, but only in the following instances: when the blood glucose is really high or really low, which means greater than 175 or less than 90. Also, after the infusion has been stopped or decreased more than 50%, again, the risk of hypoglycemia. After an IV regular insulin bolus is given, again, this would be only in cases where you've gone very hyperglycemic, and also after the initiation of enteral nutrition. So to highlight, this is only for the first meal. So again, most of the time it will be Q1 hour AccuChecks, except when you're very high or very low and you're just starting the first meal. Now, in terms of initiating the insulin infusion, most of our cases, as we've seen, the insulin infusion is actually started in the OR and continued onto the floor. And in these cases, you would just then continue to titrate the infusion based on the titration guidelines on page 2 to 3, and page 1 would not be as relevant in these cases. Now, if the insulin infusion for some reason has not yet been started, then you would proceed with Q-hour blood glucose checks, and the trigger for starting the insulin infusion would be when the blood glucose is greater than 125. So when you are initiating the blood glucose, there are two questions to consider prior to initiation. One, is your patient diabetic? And also, if your patient is diabetic, are they on prior insulin or are they non-insulin dependent? So of course, this review can be done through the patient's documented history as well as their medication reconciliation. So here we can see that when you are starting the insulin infusion, it's important to ask those two questions, because whether they're diabetic or not, they still may require the insulin infusion, but we can see that patients who have a prior history of insulin use will require a more aggressive regimen to start, and also for non-diabetics to start, they might not require a bolus. So those two questions are very important when you're first starting the insulin infusion. Is your patient diabetic? And also, if your patient is diabetic, were they on insulin? Do they have a prior history of insulin use or not? Now, proceeding on to titration of the insulin infusion. Titration, as you can see from page 2 to 3, we can go over every single bracket. And you've all been used to titrating an insulin infusion before, so it's not so much different from the prior protocol. This is, of course, based on blood glucose check results, and as with any protocol, large decreases in blood glucose levels will require decreases in the insulin infusion rate, and large increases will require increases in the rate, and or an additional IV bolus. Now, most of the time the patient will be in target range. If the current blood glucose level is within 10 milligrams per deciliter of the prior blood glucose level, when the patient is in target range, then generally you will keep the patient at the same rate. However, one thing that I do want to note in this protocol that might require extra reading, so we might miss it if we don't read into the protocol, is even when you are in target range, again 100 to 150, you must always take into consideration consistent trends. So look always at the last 4 blood glucose levels. By doing this, we'll prevent the patient from slipping out of target range. So if you look on page 2, you can see that in the target range of 100 to 150, it'll say excellent, and you weigh. You look at patients in this target range, but even if they're within 10 milligrams of the last glucose, you will keep the patient at the same insulin rate unless you see consistent trends. So again, if the patient is increasing in each of the last 4 measurements, then you would preemptively increase the rate by 0.2 units per hour. Conversely, if they're decreasing and they're trending toward hypoglycemia possibly, then you would preemptively take initiative and decrease the insulin rate by 0.3 units per hour. So to illustrate this concept, we can look at this patient. So from 1700 to 2000, we can see that the patient is within the target range of 100 to 150, but you can see that it's slowly trending up, 131, 133, 134, 136. So at the point where you get that 136, you would actually take initiative and increase the insulin rate by 0.2 units per hour, so we can prevent the patient from trending outside of the target range. And another thing I wanted to point out is, even when you do take action and increase the rate from 2.5 to 2.7, you don't start over with another 4. you always look at the last preceding 4 glucose levels, and you can see that in this case it still keeps on trending up at 2100, so you would again take action and increase by another 0.2 units per hour. To address hypoglycemia, in the Portland protocol, there's actually a very low documented risk of hypoglycemia, around only 0.5%. However, I do want you to note that blood glucose levels greater than 80 will lead to stoppage of the insulin infusion. If you could look at the detailed instructions on page 2 on how to approach hypoglycemia, depending on the severity of the hypoglycemia, it may require intravenous use of dextrose. And also, we want to reiterate that when you are very low, then it will require a little bit more frequent AccuChecks, Q30 minutes, until the patient is back within target range. Now we'll transition into postprandial subcutaneous humalog dosing. Now this is something that is different from our prior insulin protocol, because again, we want to look at post-cardiac patients in terms of their hyperglycemia as different causes of hyperglycemia. Might need to repeat this slide. So again, now we'll transition into postprandial subcutaneous humalog dosing. What we want to look at with Portland protocol is that it addresses post-cardiac patients and 2 different causes of hyperglycemia. One is there's post-surgery hyperglycemia due to stress hypoglycemia, which will be controlled with insulin infusion, and also cardiac patients that then proceed to enteral nutrition will have post-meal induced hyperglycemia, which in this case we're going to be controlling with additional subcutaneous humalog. So now we'll proceed on to page 4 to 5, and these are the pages that address subcutaneous humalog dosing. And we can see that it may look a bit confusing at first. We can see that the first meal is depicted on page 4, and page 5 will be titled subsequent meals, and it has very similar row numbers on it. So a couple questions that you should be asking are, what's the difference between these 2 charts? These are both abbreviated versions of what you have on page 4 to 5. And also, what do these row numbers mean? And we'll go into that in the preceding slides. Now on page 4 to 5, again, we're describing the first meal and subsequent meals. So the first meal on page 4, this will only apply to the first meal, is not relevant thereafter. So after the first meal, you'll always be looking at page 5. So key points from page 4 to 5 are, each subcutaneous humalog dosing regimen is assigned a row number. Now the larger the row number, the larger the subcutaneous humalog dosing regimen. And the humalog dosing regimen selected for any particular meal will be titrated based on how effectively the patient's blood glucose was controlled with the prior subcutaneous humalog dose, or row number, given with the prior meal. Now for the first meal on page 4, we can see that this is the first meal. Therefore, we don't yet know exactly how much humalog the patient will need. So this is an empiric dosing regimen that will be based on 2 factors: the current insulin infusion rate and how much food the patient eats. Maybe repeat that slide. So this is the first meal, which is depicted on page 4. And you can see that humalog dose base for this patient will be determined on 2 things: current insulin infusion rate and also how much the patient eats. One thing that we do need to take into consideration is this initial row number. Now again, the bigger the row number, as you can see, the more aggressive the humalog dosing. We'll take into consideration what row number the patient starts at, or what row number the patient is at for any particular meal, because this will act as a reference for the next meal. If you look at page 5, this chart will be used at all meals subsequent to the first meal. And we'll go into how this is used in the next couple of slides. As we can see, this also has a row number, and again, the row numbers will be needed to kept track of in order to act as a reference for the subsequent meals. So how do we use the row numbers? Basically, we want to answer the question of efficacy. How effective was your humalog dose on the prior meal in terms of keeping the patient's blood sugar within 100 to 150. Now, to summarize the detailed instructions above this chart, we see that the basic idea is that the patient's 2-hour postprandial blood glucose level is above the target range, then obviously the humalog dose given in the prior meal was not effective. So we will need to increase the next humalog dose for the next meal, therefore we will choose a larger row number. Now conversely, if the patient's 2-hour postprandial glucose level went below our blood glucose range, then we would need to be a little bit more conservative and give less humalog with our next meal. Therefore, you choose a smaller row number, as described in the protocol instructions. And if the humalog dose given in the prior meal kept the patient within the goal range, then we'll stay with that same dosing regimen and we'll keep the row the same. Now, key points within this humalog dosing aspect of this protocol is efficacy. Again, efficacy is defined as evaluate whether the blood glucose level 2 hours after the humalog dose or 2 hours after the meal was effective in maintaining the blood glucose within your target range. You always want to keep track of what the last row number was, because this will be a reference point for the next humalog dose and allow the patient-specific humalog titration. And third, subcutaneous humalog dosing is, again, in addition to the insulin infusion. Please continue to titrate the insulin infusion independently of our humalog doses. This may seem a little bit confusing for now, but we'll try to end this and integrate all the prior points that we've talked about in the next patient case. So in this patient case, we can see that this is our typical post-CABG patient where in the prior day they had ended surgery around 12:30. So if we assume an anesthesia end time of 12:30 p.m. on the prior day, we can see that this is now post-op day number 1. In the morning, and you're about to give breakfast at 9 a.m. So you can see that from 4 a.m. to 9 a.m. The blood glucose has been maintained within our target range, so there's been no increases in the insulin rate. Now, if we assume an anesthesia end time of 12:30 p.m. on the prior day, then remember what the skip measure is. It means 18 hours after anesthesia end time, that's when the skip window opens and will start to be examined in terms of our glycemic control. So in this case, from 6:30 in the morning to 12:30 in the afternoon on post-op day number 1, every blood glucose level within that 6-hour time window has to be less than or equal to 180, or else this patient case will fall out. So you can see that this patient is given breakfast at 9 a.m. The insulin rate is 3 units per hour. So again, with our empiric dosing regimen for that first meal, we don't have any information regarding really how much humalog insulin this patient will need. So we'll look at two things again. One, the insulin rate, and also how much the patient eats. So again, the insulin rate is 3 units per hour. So if you look at page 4, this is your first meal chart. So in this patient case, the patient eats greater than 50% of their meal. So if you look at the initial row number 2, this will tell you that the patient requires humalog 6 units subcutaneous times 1 to be given right after the meal. Now again, to reiterate, starting with the first meal and the first meal only, we will need to increase the frequency of the blood sugar AccuChecks to Q30 minutes times 4, which is depicted here. And again, this only applies to the first meal. Now remember, throughout this whole postprandial humalog subcutaneous insulin dosing, we're still concurrently titrating the insulin fusion. Everything with regard to insulin fusion on page 2 to 3 is kept exactly the same, and this is in addition to your postprandial humalog dosing. So as we can see here, despite the patient getting breakfast, we're still looking at the blood glucose levels Q hour to Q30 minutes, depending on that first meal, and we can see that when we look at the last 4, it's starting to trend up. So at 10 o'clock, because the last 4 glucose levels have gone up, you're going to take initiative and increase the insulin rate by 0.2 units per hour. Now we go on to the next meal at lunchtime, to be given at 1300. Again, you continue to titrate the insulin infusion per protocol independently of the humalog dosing. Now the question for lunch will be, again, how much humalog do you give after lunch? So in order to answer this question, we'll have to answer the question first of, was the prior humalog dose effective at breakfast time? So we look at breakfast was given at 9 a.m. and that's when the first humalog dose was given. So now 2 hours after this, we'll have to see what the blood glucose level was. So at 11 o'clock we can see that the blood glucose level rose all the way up to 165. So again, 165 does not constitute a fallout, but it does show that the patient after breakfast went above our target range and in effect is hyperglycemic. So we can say that the humalog dose of 6 units given at breakfast was not effective. So we'll now have to increase the intensity of the post-lunch humalog regimen. So again, we said that the patient's 2-hour postprandial insulin level was 165. So if we look at page 5, this is the chart that we'll use for subsequent meals. Again, after breakfast or after that first meal, page 4 will be irrelevant. So if you turn to page 5 and follow along with this scale, we can see that with a 165, the patient will fall into this range. Therefore, the instructions will dictate that you need to increase the insulin schedule for the next meal, lunch in this case, by 1 row. So if you recall, on page 4, we had initially for breakfast used a row number of 2. And that's the reason why you need to remember that initial row number. So because we had used 2, that'll be our reference. So in this case, for lunch, because it was not effective and we had went above the target blood glucose range, now we have to increase from row 2 by 1 row to row 3. So in this case, the postprandial insulin glucose level was higher than target range, and now we'll choose row 3. So our patient eats 30% of their meal, and according to row 3, they'll be given humalog 4 units subcutaneous post-meal. The last aspect of the Portland Protocol is duration. Now again, the Portland Protocol will be active for at least 24 hours, and this is mainly because the CMS core measure looks at a patient from 18 to 24 hours post-anesthesia end time. Now after 24 hours, it's really up to the prescriber how they'll choose to address the patient's hyperglycemia. They can either extend the duration or transition off the infusion, preferably to a basobolus insulin model with patients that have a prior insulin use, and you can refer to the St. Francis Medical Center's Transition Orders IV insulin drip to subcutaneous insulin protocol, or they can transition to home medications. This is completely at the discretion of the prescriber. So that concludes this in-service. Thank you for listening, and please address me. My name is Peter if you have any questions regarding this protocol. Thank you very much.